over, and due to extenuating circumstances, I cannot be there. So I still wanted to give our grand rounds, and basically there would be no reason for you to remember this, but this is the background of the slide that I gave when I was applying for the position of department chair, and I'm so grateful to be the George W. Hallett Chair of Pediatrics, but it had me reflect on the successes that we've had over the past year, as well as the challenges, IT, COVID, and otherwise, and the opportunities that they provide for us going forward. So the objectives are to assess your satisfaction with the progress of the department, to describe successes in clinical care, education, advocacy, and scholarship, describe the biggest challenges we face as a department and opportunities. And my vision for the department is that the pediatric population of Maine will become the healthiest in the nation because of the collaboration between providers, families, communities to promote healthy lifestyles and promote seamless, compassionate care across the continuum of healthcare needs from primary care to intensive care. And that pediatric providers will find professional fulfillment through the work they do, both clinically and academically. And this is the slide that I was given in terms of portraying how the pediatric service line is aligned to basically do our best to provide communities with all they need in terms of primary care, behavioral health, health promotion, care coordination, and then care for pediatric patients when they're urgently ill, either in the emergency department or in the delivery room. We're also developing regional services such as outreach clinics that I'll talk about a little bit more. We have general pediatric inpatient beds at Maine General, and we may be developing a level 2 nursery in Southern Maine. In terms of our centralized resources, we have comprehensive subspecialty care by excellent specialists that compare with any children's hospital in the country. We have not only a level 3, but a level 4 newborn NICU. We have tertiary care inpatient beds and critical care. And then since I've been here, I've wanted to promote an academic culture in terms of education, QI, population-based health, practice-based research, and clinical trials. And I feel like my mission is to facilitate the alignment of pediatric programs and providers to optimize population health, our patient experience, healthcare value, and provider satisfaction. And while we're all aligned, as you can see, the organizational chart for this is a bit messy with all the different service lines and departments contributing to this. Children's health basically is a complex process. If you look at the children's health ecosystem, it's influenced by state and federal government in terms of developing policies and funding sources through Medicaid. Businesses through private insurance also impact what we are paid to take care of children. Schools are obviously very important in terms of school-based health care, the environment in which children spend a lot of their time, and these days with COVID. Philanthropy, I'm very grateful. We have a wonderful philanthropy program, which really allows us to do things in terms of pilot programs that we otherwise wouldn't be able to do. As I mentioned, want to focus on our providers to ensure that they feel well supported to care for children. We have community hospitals that we're reaching out to that I'll talk about. And we also have the environment, the social determinants of health that we try to impact through the multiple programs that we have, particularly led by Steve DiGiovanni. And then we have the ability to educate and as well as do research through the resources we have at the Barbara Bush Children's Hospital. So what is a service line? Well, a healthcare service line ideally is focusing on patient-centered coordinated care. Through focusing on patient-centered coordinated care, a service line aims to provide a one-stop shop for a specific set of services. Ideally, patients receive all needed services from an integrated team of providers at a single location or set of locations. And so I would argue that this current organizational structure doesn't necessarily allow us to best align. So that's where I think the H in BBCH needs to be a flexible H, meaning that the H needs to stand for the Barbara Bush Children's Health Service Line, as well as the Barbara Bush Children's Hospital. And these two together, I think, make up the Barbara Bush Children's Health System, which consists of primary care. In Portland, it's MMP Peds and Family Medicine. Outside of Portland, it's the Child Health Service Line Medicine, Pediatric Family Medicine, and Pediatrics. It's our pediatric subspecialty care. It's our pediatric surgeons, our hospital-based specialties. And then the residents are both a value in terms of being, I think, the glue that we have excellent residents that help to hold this all together, as well as an opportunity for us to teach and prepare the future generation. So as we go through the rest of this presentation, I'd like you to think about key questions that I think we need to answer in order to be successful as a children's health system. How can we reach the best possible outcomes at the lowest cost, provide ideal patient experience, rapidly identify and adapt new innovations and insights, support and engage our providers, and harness the power of technology, whether that's the EMR or telemedicine, to provide the best value to patients and providers? Well, one key to success is having excellent faculty. And this slide depicts the new faculty that have joined since I joined the department in adolescent medicine, neonatology, developmental behavioral peds, cardiology, critical care, neurosurgery, pediatric hospital medicine, psychology, and oncology. We also have wonderful primary care faculty, both that have joined both here at MMP as well as at the Child Health Service Line sites. And if you'll notice, several of them are our recent residency graduates. So I'm very, very grateful that our residents feel that they're well enough supported that they want to continue to work within our health system. So I want to talk a bit about our successes over the past year. And this year, I think more than ever, sometimes success just means surviving. Here's a picture of Nathan Mick down in the ED, who I think wins the award for the most hours in a PAPR over this past year. But I think the Child Health Service Line has really responded amazingly to COVID-19. Special shout outs to those on this slide who have gone above and beyond in terms of developing protocols, as well as communicating with providers with the school health system. And I know that at the beginning, I felt like we were building the plane while we were flying it, trying to figure out how to best care for our patients and protect providers. And this word cloud basically depicts what I gleaned from division chiefs asking, when I asked them to send things that they were most proud of. And a lot of people focused on COVID. And so this word cloud reflects the outstanding care, research, focus on education and advocacy that all of you have contributed to throughout the Barbara Bush Children's Health System. Medical student and resident education has also been a challenge that people have arisen to meet through virtual rotations for medical students. It's adapting to Zoom precepting, e-learning, fourth year student virtual applications, and trying to keep them calm in the midst of this new way of applying for residency, and adapting to bedside family-centered rounds with social distancing. For resident education, there's also been online learning, Zoom conferences, Zoom consults. Particularly our Med Peds residents have been doing a lot in terms of caring for adult patients, PAPRs, and taking care of patients in the Pediatric Respiratory Acute Care Center. So thank you to all who have participated in student and resident education, and a special thanks to the residents. I also want to acknowledge other groups, particularly our simulation program. Leah Mallory and the simulation program were recognized this month in Maine Magazine for promoting safety innovation and for frontline providers here at Maine Medical Center. So congratulations to Leah and her team. In the midst of all this, as you know, we had an outbreak of division across the country and people really behaving poorly in terms of supporting each other. And I'm very proud to say that the pediatric department, particularly Katie Diamond Falk and Shannon Bennett, as you can see, took the lead actually for the hospital and having a moment of silence in support of the Black Lives Matter movement. So thank you. Now focusing on clinical successes. Okay, if you look at this slide, I'd like you to think about what all these people have in common and what this person has in common with them. This person who I could not find their picture on the internet, but I could find all of these other people with the same name. So this is our new oncology pharmacist, John Bork, who we all know when we see him, but I couldn't find his picture online. So I thought I would show you the other John Borks of the world. But through philanthropic funding with the MCCP board, we were able to fund his position. And I think it will be extremely helpful in decreasing adverse safety events for our oncology population. So congratulations, John. And it seems to me now like eons ago, but last year at this time, we were worried about how we were going to be able to support the number of respiratory viral cases that we were anticipating. And this is a picture of 5 Bean. It's, as you can see with the person with the PAPR, it's actually this year rather than last year, but it was a success. And it's something that we need to remember back when, of all the things that have actually gone well. Also, we've had a record number of newborns here to help support the pediatric population. And this is a slide of the 9 labor and delivery nurses who helped to contribute to the Portland pediatric population. But not to be outdone, our faculty also have contributed to growing the pediatric service line as well. And so I'd like to see if you can match the name of the baby with the baby. So for this one, we have baby Jackson, baby Fritz, not so little baby Faye, baby Z, and baby Anwar. So welcome to all of the newest members of our department. Also, Developmental Behavioral Pediatrics launched a successful clinical transformation project to streamline intake and evaluation of patients, particularly those with autism disorder. And we're continuing to work with CAD to try to better define the intake process and to try to avoid duplication of services. So that is a project that we'll still continue to work on. Gender Clinic has been extremely successful and in both caring for patients who have transgender concerns, as well as our awareness as an institution of how to provide best care for transgender patients. The Eat, Sleep, Console model was amazingly successful. Thanks to our neonatologists and all of the providers at the various community hospitals. As you can see within Maine Health, we have up to 7% of babies who are substance exposed in utero. And these are all the members of the collaborative who participated. And again, it's just amazing that back in March of 2018, there were up to 22% of babies transferred to the Barbara Bush Children's Hospital for treatment. And now that number is down to 0. So congratulations. Safe sleep is also been championed both by Jennifer Heyman and Kelly Bowden, and all of our Barbara Bush Children's Health System hospitals are Safe Sleep accredited. And with the Barbara Bush Children's Hospital receiving gold for multiple years in a row now. Thank you, Jen. MaineNet is another huge success. And this is a credit to Dr. Alexa Craig, who not only is using telemedicine to improve the outcomes for babies with neonatal encephalopathy, but has established a process of care that that has been extremely successful in terms of doing urgent telehealth simulations that we want to replicate in the NICU as well as in the emergency department through the PICU. In this model, neonatologists, neonatal neurologists, and the primary care provider all get on the same Zoom call to determine whether the infant needs therapeutic cooling, because this must be initiated within 6 hours of life, and initially was supported through research, but now is so successful that it's a part of our clinical care processes. Our telehealth strategy, if there is any positive from COVID, it's that our telehealth strategy has really been pushed forward. When this slide was initially created, we were limping along with having services at some locations, but at-home services were still being developed. And so we're light years ahead of where we were. And I think thanks to the work of Mike Dedekian, in terms of specialty care, we're looking at how can we sustain and improve our processes of care to best meet patients where they live, to provide the best care possible, both with in-person and with telehealth visits. We also have subspecialty outreach services, particularly a new site is opening at Penn Bay. It's a beautiful new building, and there will be subspecialty care there, starting with GI, endocrine, genetics, and cardiology. Our Angel Care Transport continues to provide, to bring our patients to us from across the state with an average of 1 transport a day. And I'd like to continue to work on seeing how can we continue to try to improve this service to make it more timely and to be sure that we're getting all the transports that we possibly can. Provider education is also key in terms of expanding the scope of primary care, spreading subspecialty expertise across the system, using multiple teaching strategies because we want to build a community of care. Referral guidelines were developed in the past by Mike Dedekian and Brian Youth. We have Project ECHO, Partnerships in Pediatrics, spearheaded by Lorraine McElwain, and then simulation outreach that I'll talk to you a little bit more about. Project ECHO, the combination of short didactic along with sharing different cases to increase the capacity of learners. This year, the focus has been on children with anxiety and depression, how that impacts children with chronic illness, other common conditions in the areas of GI, endocrine, and pulmonary, and how to co-manage patients with chronic illness. Special thanks to Noah Hoffman, Sam Piro, and the panel of experts here. We've done neonatal outreach simulation starting over a year ago at Southern Maine. We've also gone to Franklin, to Waldo, and we plan on going out to other sites. This is basically a simulation roadshow where you see we have our simulation experts, we have all the simulation equipment, we have nurses and neonatologists who come to do a day-long simulation training. So despite our many successes, we do have threats. And I think particularly now that telemedicine has been pushed forward, I think our friends to the south at Boston Children's and MGH continue to pose a threat in terms of our market share. We have a collaboration, as you know, with Boston Children's that we want to continue to develop in such a way that it helps grow our programs and keep Maine patients in Maine, not reach patients and get them to go to Boston. I think we also need to continue to outreach to Eastern Maine Medical Center to direct those referrals to us rather than down to Boston. In terms of challenges for the health service line, social determinants of health continue to be a challenge just as they are across the country. Well child checks with COVID, ensuring that we have point of care lead testing, HPV vaccination, access to pediatric specialists, especially mental health providers, variability in neonatal outcomes, adolescent vaping. Within our children's hospital, we need rehab services, both inpatient and outpatient, and eating disorders program. We need to work on our care for extremely premature infants, because now many hospitals are having good outcomes, even as low as 22 weeks. We want to improve our interprofessional nursing and subspecialist collaboration on the Barbara Bush Children's Hospital inpatient unit and improve the efficiency of rounds. The PICU is going to be working on an ECMO program, or they already have, that will be launched soon. And then both the service line and the hospital, we need to work on improving the care of our medically complex patients, and this may include starting more multidisciplinary clinics. We need a pediatric orthopedic surgeon, and I want to continue to promote academic scholarship in the vein of, we need to share all the great work that you all are doing. So in terms of the service line, we need to continue the great work that has been spearheaded by Steve DiGiovanni, by Tori Rogers, to continue to improve things like trauma screening, which is already very remarkable. We're starting a program to recognize excellence in primary care by recognizing practices that are meeting high quality standards, leverage the Barbara Bush Children's Hospital brand, and to communicate to practices to communicate to families that branded practices are recognized for providing outstanding care. So we have a little bit of modest swag to hand out, as well as plaques. And in order to be recognized as one of these sites, practices have to be involved in all 6 of these health promotion programs, as well as meeting these quality metrics. These practices, I'm proud to say, have been recognized as meeting standards, and we hope to help other practices to meet them in the future. We'll be doing this on an annual basis. In terms of lead testing, I know that Cassie Grantham has been spearheading the point of care lead testing. HPV, Carolyn Zimmerman started an MOC4 project to focus on that. These are practices that are currently participating in the MOC4 QI initiative, and they've been sharing practices that other sites have emulated to increase their immunization rates. The goal is to have a 60% immunization. 60% of patients will receive 2 valid doses of HPV on or before their 13th birthday. And as you can see, there's variability across the system, but most practices are not able to meet that mark. And moreover, we really haven't been able to budget since last year. Understandably, COVID has put a big wrench in this, but we need to continue to work on this, and we'll continue. And I urge you, if you are a primary care site, to participate in MOC4 going forward. Access to pediatric specialists, especially mental health, telemedicine has been great for direct to patient, but there was a story that Kobe Wyatt told me that I think could serve as a model for some types of visits, where he had a patient that had a new diagnosis of cystic fibrosis. The patient was far away, could go to the primary care provider, but couldn't get to Portland for a period of time. So Kobe did a Zoom telehealth visit with the primary care provider. And both he and the primary care provider wrote to me to tell me how satisfying it was for them, for the patient. The patient felt supported by the primary care provider who was there. The primary care provider understood very well what the plan of care was and could help to promote that with the patient. So I think, thinking about how we can close the loop with these primary care subspecialty telemedicine consults, I think is a great practice to think about continuing. We're going to continue with Project Echo. I'm going to talk a little bit about Project Core, which is our e-consult program, and then about mental health training. So in terms of, and in addition to the types of teaching strategies that we have, e-consults I see as another strategy to help build the capacity and get up to date with latest practices around specific problems. So we're going to be collaborating with AAMC on Project Core, which is coordinating optimal referral experiences. And we want to improve the interface of primary and subspecialty care. Basically, it's a curbside consult that is kind of like on steroids, in that you pose the consult in using a template in a way that gives the specialist the information they need so that they can efficiently answer the question. And this would be done through Epic. They would have access to the chart so they can look up additional information if needed. And both parties can bill for it and get RVU credit for participating. And we think that this can help to improve the quality and efficiency of care for patients, open up specialty spots for patients who need urgent appointments. And so we're about to launch this as our clinical transformation project. And really the primary care provider is at the hub of this, and they pose questions to the subspecialist. If the specialist thinks that the patient would benefit from an in-person or telemedicine consult, there is a process by which they can convert the e-consult to that form. In terms of primary care mental health, Sam Piro, Amy Mayhew, Kate Herlihy have been very active with this, creating an inventory of community health resources with the help of Abigail Abbott, care and referral guidelines, and then there's our primary care, there's our HRSA grant. So they basically did a inventory of the different types of behavioral health providers based on the number of children in a particular practice to look for variability and gaps in representation and to advocate with those community practices for additional support where there is not enough of the behavioral health providers. Kate Herlihy has this mental health pyramid, as we call it, where it's not exactly the practice guidelines, but kind of gives an idea of the types of problems that potentially a primary care provider could manage on their own versus in the green versus those in the pink that really absolutely need to be seen by a child psychiatrist. And so what we want to do is to increase the capacity for primary care providers to be able to handle as many of the green and yellow problems as possible so that we have the capacity for the psychiatrist to see those more complicated and urgent cases. And so in that vein, we're going to develop a curriculum consisting of webinars and other resources that are currently available, like through the AAP. There'll be some ECHO sessions, as well as once psychiatry gets on Epic, hopefully then you can also pose questions through the e-consult model. Another area of healthcare disparity is with newborn care. And basically, a newborn's risk of dying or having a brain injury at birth shouldn't be determined by their zip code. We had 11,500 births last year in Maine, 31 hospitals, 23 of those had less than one birth per day. And so all these hospitals in black are hospitals that generally have, on average, less than a couple of births per day, with Maine Medical Center and Eastern Maine being the NICU sites. And through a study done by Alexa Craig, published in Journal of Pediatrics, babies born outside of Maine Medical Center or Bangor have up to 6 times the risk of death or brain injury. And so there's a variety of reasons why that is, but we want to do our best as pediatricians to try to mitigate that. And we know that newborn resuscitation training through simulation helps to improve the outcomes for babies. And so as I talked about before, we have been doing in situ outreach simulation, basically going to the different hospitals to provide simulation training, because we know that training that occurs in the practice site provides the best opportunity for best practice. But with the expense of all of the resources that are needed, both from the community hospital as well as here at Maine Medical Center, we can only get around to these hospitals once every 3 years. And so that clearly is not the best strategy for maintaining readiness. So Ali Zano and Misty Melendi are starting Project Moose, which is the main ongoing outreach simulation education program, along with our collaborators from the Hannaford Simulation Program. And our first team that we're working with is the Franklin team. And I can't thank them enough for all of the hours that they've worked with us to get the equipment installed, to get the training done, so that this can be successful, especially Emily Jacobs and Gabe Cibiello. So Project Moose, basically it's a telesimulation. The resuscitation teams at the rural hospital, where the neonatologist is in the NICU observing via cameras. The simulation can be set up by the Sim Center, run at on a tablet at the rural hospital. And then the neonatologist provides expert feedback at the end of the case, and we're recording the cases so that we can give them feedback over time in terms of areas that are improving and areas that still need to be improved. So what we're trying to simulate basically is this, a newborn, particularly with respiratory failure. And as you can see with that plastic mannequin, no matter how high fidelity it is, you're still not going to simulate the experience that you would have with the real baby. So when I was at Children's National, I worked with our e-learning folks to develop computer-generated 3D models of babies in distress. And here we have the opportunity working with Michael Ferguson, who's a very visionary in this area, to develop augmented reality simulation. And basically what that does is uses a Microsoft HoloLens to portray, as you can see here, a hologram, and people around the hologram can see it from their own vantage point for a shared augmented reality experience. So basically what we propose to do is take a static mannequin, overlay a hologram, program, and the case can be programmed ahead of time, or you can change it on the fly, just like we do with our current simulations. The expert coaches can be watching from a distance, and the debriefing can actually be much more involved using actually eye tracking. So in terms of things that we need to do to improve care within our hospital, rehab services, we're working on getting a physiatrist and some outpatient space. Eating disorders, we need to establish an outpatient program for that. Our neonatologists are working with the University of Iowa, who has the best outcomes for 22-weekers, to utilize their practices. As far as interprofessional rounding, we're working on IPACE on BBCH. Lorraine McElwain is leading that to improve our communication scores, our resident education perceptions, to And basically, the iPace team is helping us gather baseline data. We're going to be brainstorming on Friday, November 6th from 2:30 to 4:30. So please be sure if you round on the inpatient unit, you have somebody from your division represented. And then we're going to take a QI approach to implementing changes. We also want to extend our intensive care expertise to from the NICU and PICU to community delivery rooms and the ED. And so we're working on getting on-demand emergent telemedicine consults in place. And the ECMO program is being spearheaded by Michael Zubrow and Michael Ferguson to support cardiac and respiratory patients, and hopefully we'll be up and running by January. So in terms of these eating disorder, in terms of these multidisciplinary clinics, we're working on getting space and administrative support. And we'll be talking more about that. For orthopedic surgery, we're trying to sign a contract with Boston Children's to provide initial coverage at our spina bifida and cerebral palsy clinics, and then hoping to be able to eventually hire a pediatric surgeon here full time. In terms of academic scholarship, we really want to be a learning health organization and to share what works with others through our Scholars Academy. And this, when we say scholarship, we refer to all of these different areas, basically taking the time to prepare adequately, to look to see what's been done before, and to move things further. And the mission of this is to provide all of you with resources and support to identify, develop, implement, and evaluate projects to address our healthcare gaps in advanced practice. And so Alexa Craig is the director, the coordinator is the wonderful Sarah Gabrielson, and then we have our steering committee with membership benefits and the expectation that all members of the Academy are going to be actively participating in a scholarly project, mentoring others, and we want to have a community of scholars. So basically, these are members of the inaugural cohort. They get the benefit of more time from Sarah Gabrielson. We have the ability to provide up to $3,000 in funding to support the projects, and we'll do whatever we can to make sure they're successful. We're going to have our next round of applications probably in January. In terms of this year, however, although it was difficult to get this data, and I included publications that were submitted as well as abstracts submitted, just because this is such a difficult year with COVID. But I'm extremely proud of the academic productivity of our department with 70 publications, 40 presentations, 34 abstracts, 8 grants, and 7 clinical trials ongoing. Some divisions were participating together on those trials. So kudos to everyone. And really, I have to say that the reason that, well, I have to say that Abby Fleisch gets the award for the most publications, presentations, and 2 NIH R1 grants. Congratulations, Abby, who also got promoted to associate professor. I should also commend Anna Cairns for getting promoted to clinical professor of pediatrics, as well as George Russell getting promoted to associate professor. And again, our office will do everything we can to help get people promoted. In terms of our vision for the future, I think we want to promote the recognition of the good work that you all are doing, build our brand, continue to push marketing to get our brand out there, enhance skills with simulation, improve delivery room and emergency care, collaborate with Boston Children's, and then tell the world about all the good work that we're doing. And I just wanted to end by showing a video that's being used to promote our residency program, because I think a lot of it summarizes what's really good and excellent about being a part of the Barbara Bush Children's Health System.
The pediatric residency program here at Maine Medical Center is an amazing place to train.
Your experience and the prioritization of your training is absolutely at the forefront of the mission of this hospital. We're
the pediatrics hospital for Maine. Like, we are it, and so we see all of it.
Residents get exposed to all specialty care, tertiary care, kids that are referred in here for cancer treatment, or if they're born with congenital heart disease and need heart surgery. Yet at the same time, we're in the community hospital for Portland.
And we have no fellows. It's all resident driven.
They are truly your patients, even when they are sick enough that they would be sort of fellowship level patients at another center.
The opportunity to be on the front lines and be the first to evaluate a patient, I just think that's critical for the quality of training.
We're a smaller program. Our attendings get to know the residents pretty quickly.
There's only 6 of us a year, and so right from the get-go, you really get to know them as more than just coworkers. They really do sort of become your de facto family for a while.
There is something really special about working with people you actually know.
They know me as a person as opposed to just a number. There isn't a person that I wouldn't feel comfortable going to ask a question of or be like, hey, I really don't know what's happening here.
I try to remember what it's like to be a resident and try to sort of validate their feelings.
I am on a first name basis with my attendings. Because of that level of comfort I have with them, it's really facilitated a lot of teaching interactions.
A lot of my interests are oral medicine and global medicine, so I get a good mix of both of those things here.
We have a resident-run clinic, and a large percentage of our patients are from immigrant families or from families who are refugees from other countries.
My rural rotation was great. It was an opportunity to really get comfortable with some of the more routine complaints that pediatricians in the community see. It's being able to see 20 plus kids in a day who came in with everything from colds to the flu.
So residents get to see not just what the care is like, but also what the job is like. So if they're going to be a cardiologist when they're done, or intensivist, they're working with the cardiologist, the intensivist. They're seeing what those jobs are like if they were to choose that specialty when they're done with their training.
There's a lot of graduated autonomy, whatever you're comfortable with, but people will push you to do more and more on your own.
In the second and third year of training, they choose rotations that they do, experiences that they do, based on what it is that they want to do when they're done with their training.
Senior resident covering the PICU overnight, you are in charge of those patients when they're coming back from the OR, and that's a very, very unique experience.
Senior residents also hold a certain phone that takes admission calls from the entire state.
And we triage those calls. We determine how the children will be transported here, what level of care they need.
It's an incredible opportunity and one that I feel extremely lucky to have.
All of our interns take an introduction to research, quality improvement, sterile activity. Second years, they have the chance to work on some of those projects through an advocacy experience, through some other research. Third year is kind of the culmination. They present their work at grand rounds. It's really cool to kind of watch the residents come up with ideas and see them through by the time they're done with the training.
No, along my interview trail, I was told by a resident to think about your location as much as the program itself, and I think Portland in a heartbeat kind of sold all of that for me.
If you can leave the doors of Maine Medical Center and be out kayaking or hiking or running a trail, you're going to have a big focus on wellness.
You can't beat Portland. So it has oceans, rivers, mountains, all the outdoor things.
We are about 90 minutes from a lot of the White Mountains, which is wonderful if you like climbing, skiing, hiking.
We eat our way across Portland, and we eat our feelings a lot, so.
The experiences that I wanted, like really mattering to the team, has very much been my real experience.
I think it's probably one of the best places someone could live and be a resident in the country.
I can't think of many better places that you can be.
I just want them to have a passion in something. And that's what we look for in our applicants, is people who have a passion in something related to peds that they want to then use their training to do stuff that can help them see that passion through.
So thanks, everyone, for hanging in there with me. I was also going to talk a little bit about our Gallup poll results, but due to all the technical challenges at the beginning, we can do this at another time. And the good news is that although similar to the way the the health system is structured, I got reports back from multiple different sources. And so basically put pluses and minuses for whether they were above the hospital mean or below the hospital mean. And the good news is that the majority of responses in all areas were above the hospital mean, but we'll set up another time to talk about how we can improve some of the, how we can just basically improve your satisfaction with working at the Barbara Bush Children's Hospital, because it's such a wonderful place to work. And I can't thank you enough for inviting me to come here to be your department chair. I really enjoy working with you all on a daily basis. So thank you very much.